Jaundice is one of those topics that feels harder than it should. You learn it in textbooks, but when you see a real patient, it's easy to hesitate. In this video, I'll show you a simple, reproducible framework, the way I explain jaundice to junior doctors, that works for both exams and real clinical practice. Let's start with the big picture. Many students have a bad impression of jaundice. That's because it seems complicated with many details and many organs involved. But jaundice becomes much simpler once you understand bilirubin flow. Broadly speaking, jaundice is divided into two types: indirect or unconjugated bilirubin and direct or conjugated bilirubin. Let's begin with indirect bilirubin and focus on physiology first, because this part is extremely important. When hemoglobin is broken down, it produces a large amount of indirect bilirubin. This indirect bilirubin enters the bloodstream and is transported to direct bilirubin through a process called glucuronidation, which is a key function of the liver. This physiology explains many clinical conditions. In hemolytic anemia, hemoglobin is excessively broken down, so indirect bilirubin increases. In liver dysfunction, glucuronidation does not work properly, so indirect bilirubin cannot be conjugated and accumulate. In constitutional jaundice, such as Gilbert syndrome, glucuronidation capacity is constitutionally reduced, leading to mild indirect hyperbilirubinemia. These situations are common and important in real clinical practice. So, what happens to direct bilirubin? Most conjugated bilirubin is excreted into bile and reaches the intestine. There, gut bacteria convert it into urobilinogen. Most of this urobilinogen is eliminated into stool, while a small portion is reabsorbed and eventually excreted in urine. Only conjugated bilirubin is water-soluble, which is why it can appear in urine. Unconjugated bilirubin cannot. This explains classic clinical findings. When bile flow is obstructed, bilirubin cannot reach the intestine. As a result, stool becomes pale. At the same time, conjugated bilirubin refluxes into the bloodstream and is excreted in urine, making the urine dark. There are a classic and frequently tested findings. Now let's look at the normal movement of direct bilirubin more detailed. Indirect bilirubin enters the liver and is converted into direct bilirubin inside hepatocytes. It is then secreted into bile ducts and released into the duodenum, especially after meals. This is a normal pathway. So why does direct hyperbilirubinemia occur? One cause is hepatocellular injury. In conditions such as acute hepatitis, damaged hepatocytes cannot properly handle conjugated bilirubin. As a result, direct bilirubin leaks back into the bloodstream. In these cases, AST and LT are predominantly elevated. Another cause is cholestatic disease. Conditions such as primary biliary cholangitis, primary sclerosing cholangitis, and drug-induced cholestasis impair bile flow. In these cases, ALP and gamma-GTP are more prominently elevated. A third cause is extrahepatic bile duct obstruction. Common examples include gallstones and malignancies. When bile cannot flow out, conjugated bilirubin accumulates and lead to jaundice. Imaging studies such as ultrasound or CT are essential, and depending on the location, conditions such as pancreatic cancer or pancreatitis may be involved. Now this is a very important point because it is often misunderstood. Direct hyperbilirubinemia itself does not always cause itching. Itching occurs when there is cholestasis. In cholestatic conditions, bile acids are retained in the body, and these bile acids, not bilirubin, are what cause the itching. That's why patients with cholestatic disease or bile duct obstruction often complain of severe pruritus, while patients with hepatocellular injury may not. Now let's make a key clinical comparison. In cholestatic causes of direct hyperbilirubinemia, patients develop itching, stool becomes pale, and urine becomes dark, because conjugated bilirubin, which is water-soluble, is excreted in urine. In contrast, indirect hyperbilirubinemia does not cause itching. Stool color is usually normal, and bilirubin does not appear in urine. This difference is extremely important for both exams and real clinical practice. Finally, here is a take-home message. Jaundice is not about memorizing lists of diseases. It's about reproducing bilirubin flow in your head. If you can do that, jaundice becomes simple. Stay calm, act first, and I'll see you in the next video.